Our next keynote speaker, Beth Fisher, and I'll invite Carly Weinstein from our biokinesiology and physical therapy division to come up and introduce our speaker.
Thank you, Yang. So I'm Carolee Winstein. I'm a professor in the Division of Biokinesiology and Physical Therapy, and it gives me great pleasure to introduce our next speaker, which is Dr. Beth Fisher. Beth is a professor of clinical physical therapy in our division, and you may not remember this, the students probably won't, but Beth gave a talk here in 2012 titled The Central and Behavioral Effects of Exercise in the MPTP lesioned mouse and its patients and in patients with Parkinson's disease. So our last speaker talked about the importance of animal models for translation, and Beth is truly a translational scientist, as she began with an animal model, the MPTP model, and she's going to now tell you the work that she is doing with humans, getting at this effect of exercise and Parkinson's disease. So Beth, without further ado.
All right, well, okay, well, so as Dr. Winstein said, I'm going to be sort of continuing where I left off, talking about optimizing motor learning in individuals with Parkinson's disease. So as Dr. Winstein had mentioned, in 2012, I had the privilege of presenting our work at Dentistry Research Day, and it must have been a very good talk for me to be invited back again this year. But basically, we demonstrated the benefits of exercise on brain and behavioral recovery first in animal models of Parkinson's disease and then in humans with Parkinson's disease. So just summarizing where we left off or reviewing that work, we were the second group to publish brain changes, neuroplasticity, in an animal model of Parkinson's disease with exercise physical therapy. And we were the first group to publish beneficial brain changes in humans with Parkinson's disease following intensive exercise. And I'm very proud of the fact that physical therapy intervention with individuals with Parkinson's disease has really dramatically been impacted by our work and others that are doing similar work. And as of now, individuals with Parkinson's disease are seen much earlier than they were previously. The training is much more intensive than it was originally, and there's a greater emphasis on challenging impaired systems rather than just compensating and helping people adjust as they inevitably decline. So now it is well understood that exercise is beneficial for Parkinson's disease. Importantly, what the evidence suggests is that the key ingredients that need to be a part of that exercise program, whatever it is, are both a skill acquisition motor learning process in addition to a physical challenge. And both of those key ingredients are needed to optimize outcomes for people with Parkinson's disease. There have been benefits of exercise in Parkinson's disease in a huge variety of tasks, and they've been identified in all of these studies in which you can see participants are engaged in multiple different tasks. So despite this wide spectrum of exercise modalities, these studies are linked in that they incorporate the key ingredients of physical challenge in the context of motor learning through feedback, engagement, repetition, complex movement practice, motivation. So the more we know about the field of motor learning and research that has specifically asked what are the important motor learning variables that will enhance the benefits of skill training in Parkinson's disease, the more we may be able to positively impact, even potentially slow down the progression of this neurodegenerative disease. What you're looking at are training variables that have been studied in the field of motor learning, 3 of which we will look at today and identify the profound impact that they have on motor learning in Parkinson's disease. And those are context, instructions, and motivation. So starting with context, the idea here is that while the environmental conditions under which a task is performed and learned may be incidental to task performance, for example, learning a list of words while sitting in a blue room, a room that's painted blue, it has been consistently observed that an individual can demonstrate superior performance if the testing context is the same as the practice context. So if those same individuals then recall the words that they learned and they're back in that blue room. While performance may worsen if the testing and practice contexts are different. This phenomena of better performance in the original practice context is termed context-dependent learning. I'm very happy to describe Alice Lee's dissertation work that was completed during her PhD with me. Dr. Lee is now an assistant professor at National Taiwan University. One of the most well-known empirical examples of context-dependent learning in motor tasks observed in daily life is the home field advantage, in which athletes usually have a better chance to win a game when it is played on the team's own practice field. Wright and Shea were the first group of authors in 1991 that used a systematic method to test context-dependent learning, motor learning, in healthy young adults. And the study design of the work I'm going to share with you was adapted from the design of their study. So it's important that you understand that it's completely normal to use the environmental context for learning. It becomes a problem when there is an over-reliance on the context. And it seems that there may be an over-reliance on incidental context in people with Parkinson's disease. Neubauer in 2001 demonstrated that individuals with Parkinson's disease were unable to transfer motor skills that they had learned in the home environment to the clinic environment. So Alice was interested in answering this question: do individuals with Parkinson's disease demonstrate greater context dependency than healthy individuals during motor learning? So her study design, she recruited 2 groups of subjects, individuals with Parkinson's disease and non-disabled healthy controls that were age-matched. And she had both groups of subjects practice a task on day 1, 324 trials. Then 24 hours later, they came back for retention testing under 2 conditions, the switch condition and the same condition, and I'll explain that in detail. So the task itself was a finger sequence task. It was actually 3 4-element sequences, and there was, they were performed with the index and middle fingers of both hands with equal alternations between the hands. And the context were colors, so that the different sequences, the 3 different sequences, were embedded in different colors. So you can see 4213 is embedded in blue circles, 3142 in red, and 1324 was embedded in yellow. And also location on the computer screen. So whether it was on the top of the screen, in the middle, or at the bottom. Now, those sequence context associations were not told to the participants, so they did not have any idea about that. They were just told that they needed to complete the sequence as quickly and as accurately as possible when it appeared on the computer screen. And this is basically how the task went. They would see the sequence on the computer screen, and then they would basically press press the keys associated with that sequence, and they were given feedback as to whether or not they completed the sequence correctly and how much time it took them to do that. So I told you I'd give you more details about the testing conditions on day 2. The retention test conditions were that the subjects would come back 24 hours later, and they would either perform the sequences again under the same conditions that they had practiced them on day 1, or they would perform them under the switch condition. So this is where that same sequence was now embedded in a different color and was in a different location on the computer screen. The main outcome measure was total time accuracy cost, and so total time AC, TTAC, which took both speed and accuracy into account. So TTAC was calculated as a measure of performance that could be used to account for any differences in error rate between individuals with Parkinson's disease and non-disabled age-matched control subjects. Total time was then further decomposed into response time and movement time, and those were measured as well. The index of context-dependent learning was something called the switch cost, where you basically took the time to perform in the switch condition and normalized that by the same condition. So this is an example of the results of this first study, and what you're looking at is on the x-axis is the practice block, and the y-axis is the total time accuracy cost value. So clearly in this figure, a smaller TTAC value indicates better performance because they're getting faster. The blue circles are people with Parkinson's disease, and the red square are the data from the non-disabled adults. So block 1 to 12 were the day 1 practice trials, and then you see day 2 switch and same. So both groups, you can see, improved significantly the first day of practice, and not surprisingly, the Parkinson's disease group was consistently slower and less accurate than the control subjects. Now, if we look at the end of practice and compare that to our retention test, switch and same, we're going to basically blow that up and look at it very specifically. We look at the end of practice and compare that to the same retention condition. We see that the performance was the same for both groups, basically, as far as their end of practice performance to the next day performance. So we would conclude that both groups of subjects learned the motor task. However, if we compare end of practice with the switch condition, we see a different picture. So now you see that we might conclude individuals with Parkinson's disease demonstrated a greater decrement in total time accuracy cost than the control participants under the switch condition. Looking at the switch cost data, but all in total time accuracy cost, reaction time accuracy cost, and movement time, basically the individuals with Parkinson's disease had a greater switch cost. So what the results of this study showed was that individuals with Parkinson's disease demonstrated greater context dependency than the control participants. So basically that's our summary. Individuals with PD are more context dependent than healthy controls during motor learning. Given the known pathophysiology of Parkinson's disease, which is impairment in the dorsal striatum of the basal ganglia, we consider that that must be part of the neural network that leads to greater context-dependent learning. Specifically, we determined or considered that the frontostriatal circuit, we hypothesized that that may be the source of context-dependent learning, given that it plays an important role in processing contextual information. And the components of the frontostriatal circuitry are the dorsolateral prefrontal cortex, which receives and encodes contextual information, and the dorsal striatum functions as a gate or modulator to select and integrate information that is relevant for generating an appropriate task goal. Since there is known damage to the dorsal striatum in Parkinson's disease, perhaps we can interfere with the encoding of incidental information. So we specifically hypothesized that if we used brain modulation of the dorsolateral prefrontal cortex, given that the dorsolateral prefrontal cortex plays this very specific role in encoding contextual information, if we decrease the activation of DLPFC, and by doing so saw a decrease in context-dependent learning, then we establish a potential source of the problem, that individuals with Parkinson's disease are encoding all of this information, much of which is incidental, without a good working filter. So how can I modulate brain excitability? Well, we can use transcranial magnetic stimulation and specifically modulate cortical excitability with repetitive TMS. Low-frequency repetitive TMS is known to be inhibitory, so basically decreases excitability of the neurons, and so we determined that we could use RTMS to downregulate DLPFC. So Alice basically utilized the same study design except for the addition of 2 more groups of subjects. Now, all of the subjects in this study were people with Parkinson's disease. What she did was she had a group that had DLPFC downregulation prior to day 2 switch same retention tests, and she also had a group that had vertex stimulation prior to switch same retention tests. The vertex is basically the center of the brain, and it served as the TMS control group, so to speak, to demonstrate that if there is an effect from our downregulation of DLPFC, then it's site-specific. And it is also, we introduce a magnetic field when you do TMS, so this was a way to be able to control for noise, any noise introduced by the TMS. So now let's look at the results. So again, all the groups did, improved over practice. Prior to the retention test, they had the downregulation if they were in the RTMS vertex group or RTMS DLPFC group. And let's look at the results, basically. What you see, again, end of practice compared to the same condition, there was a slight decrement, slight increase in time for all the groups, but not significant. Basically, they learned the motor task. But if we look now at the switch condition and compare that to end of practice, we see basically that the decrement in total time accuracy cost was less in the DLPFC group compared to the control and vertex groups under the switch condition. And looking at switch cost, we basically see the same thing. So the DLPFC group demonstrated less context dependency than the no TMS control group and the RTMS vertex group, both in total time accuracy cost, response time, and movement time. So RTMS to DLPFC reduced context dependency. RTMS may disrupt the process of encoding new context in the DLPFC. We didn't see any differences between the control and vertex groups, which basically establishes that context-dependent learning is specifically related to the DLPFC. And the thinking being that relative overactivation of the DLPFC in individuals with Parkinson's disease leads to context being encoded, and then there's reduced filtering because of a damaged striatum of this incidental information. If we downregulate DLPFC, we essentially minimize the context-dependent learning. So, optimal training strategy, if you don't have TMS available, consider that individuals with Parkinson's disease may utilize external environmental information excessively, and because of this over-reliance, it limits generalizability of learned tasks from one environment to another, excuse me. And so we thought maybe in the early stages of Parkinson's disease, people should be exposed to various environments, really challenge them to be able to generalize between environments in performing a task. And then perhaps in later stages, you're training more in the environment that the individual will perform the task. Okay, so having talked about context, now let's talk about instructions. So it turns out that how you give instruction to an individual, to any individual, is actually very, very important. And specifically, external focus of attention. So experimental evidence has basically, really grown for the benefits of adopting an external focus on the intended movement. Basically instructing someone to attend to the effect of their action on the environment or on the implement, as opposed to an internal focus on the body movement itself. So an external focus of attention enhances learning by reducing a focus on the self and directing attention to the intended movement effect. So this was not work done in my lab, but by colleagues of ours, and it was looking specifically at individuals with Parkinson's disease. So there were 14 participants diagnosed with idiopathic Parkinson's disease, and they were asked to balance on an unstable surface, so this inflated rubber disc, and in counterbalanced order, so within subject design, they were instructed to focus on reducing movements of their feet. So that was the internal focus instruction, or to focus on reducing movements of the disc, that was the external focus instruction, or they were not given any attentional focus instructions. A portable force platform was situated under the rubber disc, and center of pressure was recorded. So what was measured was the root mean square error of the center of pressure vector magnitude, and that served as a measure of postural sway. And what they found was a significantly reduced postural sway in the subjects when they were basically utilized the external focus instruction compared to internal control, which there were no differences between those two. So basically, this work tells us that subtle instruction distinctions that direct attention to movement effects external to the mover reduce postural instability during standing for individuals with Parkinson's disease relative to an internal focus. And these findings have, potentially very important implications for instructions given by clinicians and the reduction of postural sway and maybe even fall risk. Okay, lastly, motivation. So just look at the green dots right now, and what I want you to recognize is that there are really shared neural substrates of the motivation network and those same neural substrates impacted by Parkinson's disease. So does that tell us that it's possible that we can exploit the brain's capacity for repair by manipulating motivational variables? One way that motivation has been manipulated is by providing a statement that enhances an individual's expectations of how they will perform. So just to give you a picture of that, this was a study that was conducted with older adults attending a university physical activity program. There were two groups, and one group was the enhanced expectancy group, and they were given this statement: active people like you, with your experience, usually do very well on this task. The data, basically, now you're looking at time and balance on the y-axis. Oh, I didn't mention. So the goal of the task is this, it's called a stable Ometer task, and the goal is basically to maintain the platform level for as long as possible, up to 30 seconds, 90 seconds. That's the goal, is for the subject to maintain the platform stable. So time and balance is the outcome measure, and that's on the y-axis. And what you can see pretty clearly here is that, especially looking at the retention performance, again, 24 hours later, that the group that really learned this task were the group that were given the enhanced expectancy statement. So Yu Chen Chung, also a former PhD student in my lab, now a postdoc, was interested in work that demonstrated that low expectations in people with Parkinson's disease were related to poor motor performance. So studies had shown that low balance expectation or low balance confidence was associated with poor gait and balance performance. But what had not been done, and what Dr. Chen was interested to know, was would motor performance in people with Parkinson's disease improve if expectation was enhanced? So she was really interested in more of a causal relationship. And again, it's quite unique to think about considering Parkinson's disease as a motor disease, that low self-confidence may be a factor in what produces poor motor responses. So that was the aim of her study, to investigate the impact of enhanced efficacy expectation on motor performance and learning in individuals with Parkinson's disease when practicing a complex balance task. And her hypothesis was that by providing this enhanced expectancy statement or package, people with Parkinson's disease would improve motor performance and learning compared to a control group. So she used basically the same stable Ometer task. It was a different stable Ometer, though, much smaller, much more difficult task. And again, but the task goal to keep the platform horizontal or level for as long as possible. So in her study design, both groups of subjects were people with Parkinson's disease. And she had two groups. She had an enhanced expectancy group that basically received an enhanced expectancy package. They got a statement prior to practice trials, and the statement was, at the beginning, it is common to have relatively big movements of the platform, but this is the type of task that you get better at with practice. Your improvement across trials will reflect learning and that you're getting the hang of it. This is a task that people of all ages have learned to do well. So that was one part of the enhanced expectancy package. They also got, throughout acquisition, the definition of a good trial or performance criteria. And they got that twice. First, before the acquisition trials, that was the baseline time plus 2 seconds, and the second time was somewhere in between the acquisition trials, and that was the baseline time in balance plus 3 seconds. So they were told something like, an example, if my baseline time was 6 seconds, they would be told, well, a good trial is going to be 8 seconds. That's considered as a good trial. That would be the first performance criteria they'd be given, or the second time would be balance for 9 seconds is considered a good trial. Then that was compared to the control group that didn't have any advanced or enhanced expectancy information package given. There was also a questionnaire that was given at the end of acquisition, at the end of retention, which is important for discussion later. The major, the primary outcome measure was time in balance, as is typical of these stable Ometer tasks. And so it was the total time when the platform angle was within plus or minus 5 degrees. And again, these were the participant characteristics, all individuals with Parkinson's disease, the enhanced expectancy group, the control group, and no differences in terms of their years since Parkinson's disease, the severity of their Parkinson's disease as evidenced by the Hone and Yar stage, or their score on the Unified Parkinson's Disease Rating Scale. So let's look at the results. Again, y-axis is time in balance. And what you can see here, basically, is both groups improved over practice and during retention. And in fact, there were no group differences in time in balance in acquisition or retention. So that did not support our hypothesis. And basically, the enhanced expectancy group did not show improved performance or learning compared to the control group. So maybe in this, disease state, just by enhancing someone's confidence, it's not going to really improve their motor capability. But Chen paid real close attention to the questionnaire results, which were very interesting. So this was the questionnaire, and there was questions like, how concerned were you about your performance? How nervous were you before the start of each trial? And what she actually saw was that there was a significant difference between the responses of the enhanced expectancy group and the control group. The enhanced expectancy group was much more nervous. So she hypothesized that increased nervousness may have negatively impacted performance and attenuated the effect of the enhanced efficacy expectation. So she added a third group and to determine whether increased anxiety as a result of performance criteria would attenuate the impact of enhanced self-efficacy. So adding that second part of the enhanced expectancy package, the performance criteria, that's a typical way that efficacy expectation is enhanced in these studies. But Chen hypothesized that the performance criteria, or the definition of a good trial, may have increased nervousness in these individuals. So she tested another group of subjects that were given the enhanced efficacy, enhanced expectancy statement without the definition of a good trial. So it's basically the same study design, same statement given, but without any performance criteria mentioned, and compared to a basically a control group of individuals with Parkinson's disease. So this was the additional 12 subjects that she added, and again, no difference in any Parkinson's disease metrics. Now, just looking at the questionnaire results, she basically supported the first hypothesis that anxiety in the enhanced expectancy group would be reduced by removing performance criteria. So now there's no difference at all in nervousness between the two groups. And as far as the stable Ometer performance, there was a trend with a moderate effect size that the enhanced expectancy group that did not have any definition of or performance criteria had longer time in balance than the control group at retention, basically supporting the hypothesis that enhanced self-efficacy without simultaneously inducing anxiety would improve motor performance and learning of a complex balance task in individuals with Parkinson's disease. And just to add back the results of the enhanced expectancy group that received performance criteria and comparing that to the enhanced expectancy group without, it really made a big difference. So summary of the main findings: enhancing self-efficacy without simultaneously inducing nervousness appear to improve motor learning in individuals with Parkinson's disease. So what does that mean in terms of clinical implications? Well, it tells us that we have to consider the impact of these psychological factors, that truly a component of movement dysfunction in people with Parkinson's disease may be low self-efficacy. So boosting self-efficacy and or alleviating nervousness may be an effective strategy to optimize the effectiveness of rehabilitation. So putting it all together from what we did in 2012 and what we've added, we now know that physical challenge and goal-directed motor learning are key factors for improvement in people with PD, both brain and behavior. And now looking deeper into the motor learning practice literature, we have identified that context, instruction, and motivation are key practice variables that should be considered in rehabilitation. Specifically, we want to have people practice tasks in multiple environments. We want to provide external focus instructions, and we want the environment to be motivating, to enhance self-efficacy. Well, all of that leads us to the current studies we are conducting using virtual reality for locomotor rehabilitation. And importantly, virtual reality incorporates all the motor learning practice variables known to impact motor learning for people with Parkinson's disease. So it enables creation of a variety of environments in a safe setting, so combating context-dependent learning. Automatically incorporates external attentional focus, and it's a highly motivating environment. Those of you that are much younger than me and played games through your high school and junior high, you know how motivating it is to be in that gaming environment. It also mimics challenges of the real world, obstacles, crowds. What we basically have as our overall goal of the study is to improve the ability of people with Parkinson's disease to perform complex locomotor tasks, to be able to negotiate the environment. They end up staying at home because they can't, manage obstacles. So we're really adapting these environments through personalized virtual reality-based physical rehabilitation. And the approach is to employ a user-centered iterative design process where potential stakeholders are engaged through all stages of development. And this is our team. So we have members from the Division of Biokinesiology and Physical Therapy, and then we have individuals from design, USC School of Cinematic Arts, that are part of this, and importantly, our team leader, the PI, Dr. James Finley, who said he was going to stay. There he is. Okay. So this is a great video that really gives you an idea. What's really nice is on the left-hand side, what you see, or actually your right, you actually see the individual moving in the virtual world, but on the left-hand side, you actually see what he sees. So if you look at this again, there's feedback in terms of how much time is left, how many more targets he needs to hit, and this is very external focus driven, because we know that people with Parkinson's disease end up very flexed, and rather than saying, straighten your back, have a straight spine, we're basically having them reach for targets overhead and achieve that extended position, but not by being told what body part they need to move. And then you can look at the modification of the environment and how we can progress the challenge by now having targets that are moving and those black spots on the floor basically represent holes that the subject is not supposed to step into. Oh, okay. Now, this is what's surprising. Even with all of these potential benefits of VR, the effectiveness of virtual reality in rehabilitation has not, the evidence is not really strong. It's actually been very limited. So as part of our first aim, we wanted to understand why that was the case. A lot of this work was carried out by R.M. Kim, unfortunately not my PhD student. She is studying with Dr. Finley. And in this first stage of the study, patients with Parkinson's disease played 4 off-the-shelf or off-the-shelf VR games, and a clinician, a physical therapist, was yoked to that individual and played the same games. And afterwards, all subjects filled out multiple questionnaires that related to engagement, difficulty, fatigue, and big picture are what we've found is this: virtual environments that are enjoyable and motivate performance for patients may not be the same environment as what a therapist or researcher determines is most appropriate for the patient. So what you're looking at is an example of some of the findings where we saw that the therapist identified a game completely 180-degree opposite in terms of importance than the patient. So this led us to the idea that limited effectiveness of rehabilitation using VR to date, to this time point, may be due to a disconnect between the therapist, researcher, and patient's perception of the type of VR experience that would be most effective in generating necessary motor and cognitive challenges to ultimately improve function. So overall conclusions: exercise that requires physical challenge within a motor learning environment appears to be beneficial for brain repair and functional improvement in individuals with Parkinson's disease. That's the very good news. Motor learning practice variables known to impact learning in individuals with Parkinson's disease are context, instruction, motivation. These practice variables and more, feedback, for example, can be manipulated in virtual reality, making this environment optimal for rehabilitation, particularly when user preference is considered. So thank you very much for your attention. Everybody's so tired. Compared with
peripheral stimulation. Like peripheral stimulation through exercise and
Oh, I see
synthesis
what you're saying.
of
I
motor
see. Yeah, yeah. That's a very good question. We haven't actually combined those two to look at, central and peripheral stimulation, like stimulation through exercise and this downregulation with TMS, and that would be a very good approach to take, or it's the comparison of that. But so what I do think, and I don't know if this answers your question, but I think that it's in the not too distant future, these kinds of things like TMS will be available in clinics, and it's possible that we could do some kind of downregulation prior to physical therapy or occupational therapy or some type of exercise rehabilitation, and that we could, balance this excitatory inhibitory input in the brain and then pair that with practice and see better effects. There has been some evidence in the stroke literature that paired physical therapy with a downregulation paradigm with TMS is better than physical therapy alone. Yeah.
So I just have a question, just reminded me of that. So with these patients, there's probably a lot of variability in the medications they were on, and how did you account for that?
Yes, very good. And so I didn't discuss those details. So because we've generally been studying earlier patients, people that are not experiencing off states, so they are really maintained on their medication and don't really have motor complications like on and off states. So we essentially control for medication state by testing them relative to when they took their medication each time that we do the testing. And then as far as we can calculate basically dopamine equivalent and compare across individuals with way different, drug cocktails or drug regimens, but we basically have pretty much equivalence as far as medication. Now, I will say we have had some earlier subjects in trials that don't want to take any medication, and they actually don't benefit as much from the exercise as possible because they're not medicated optimally. So we're not saying exercise replaces medication, but that the combination is what is critical. Yeah.
Hi, that was a really interesting talk. I really appreciate that. As neuroscientists, I come from basic biology, so they often see the connection. My mom's also. But I was wondering if you had thought about this relationship between the enhanced experience group and the placebo effect in general as it applies to these kinds of treatments, not just in this context but others. And also, what if you thought about the mechanisms that might contribute to this positive effect? There's certain circuitry you're thinking about that might be positive.
Yeah, well, there's definitely a motivation circuitry. There's definitely neural substrates associated with motivation. As far as the studies go, the control groups, it's pretty distinct as far as one group getting enhanced expectancy statements and one group not at all. So, but placebo effect in terms of an investigator being there, I would say it's probably much grayer and much muddier in the clinic itself when we've attempted as researchers to basically distinguish an enhanced expectancy group from a non-enhanced expectancy group, but therapists tend to generally be excited and enthusiastic, and they want to motivate their patients to practice, so it gets a little bit muddier. Did that answer your question? I mean, I think then we're not really able to compare the effects of providing this statement that is supposed is to boost confidence, basically. Okay, thank you so much.